Welcome to HealthCast, the heartbeat of health IT. I'm Alexander Bolova, production lead at GovCIO Media and Research. With me today is staff writer researcher Nikki Henderson. Hi, Nikki.
Hi there, Alex.
So you had the opportunity to chat with Mickey Tripathi, National Coordinator for Health IT at ONC. How'd it go?
Well, it went very well. Alex, Mickey, and I had an amazing conversation. The main focus of our discussion was health equity, which is a top priority for ONC. Mickey talked about the U.S. Core Data for Interoperability Draft Version 5, which was released earlier this year, and he talked about how it will help reduce health disparities. He also shared a few details about the agency's health IT certification program and what impact it will have on health equity related data. So it was a really great conversation.
Yeah, sounds like it. So tell me more about ONC's white paper on health equity by design. What did Mickey specifically say about this type of approach and how it will help to eliminate individual disparities as well as build a more equitable future?
So the Health Equity by Design concept paper was released back in April, and it's designed to advance data equity. The approach focuses on implementing health IT policies and programs for everyone, including those in underserved communities. So Mickey said this approach also looks at software development and business processes in other areas like safety by design, security by design, and privacy by design. And this is all going to help build that more equitable future and result in better health outcomes for everyone.
So what did Mickey say about the emerging technologies ONC is using to address algorithm bias and to possibly close some of the health equity gaps?
Well, Mickey talked a great deal about AI. I'm sure that's no surprise. The many ways ONC is utilizing it, which is in a lot of areas. AI is helping in the area of analytics. Mickey also talked about how AI tools are helping with patient demographics. It's also being used to figure out whether a person is at high or low risk for certain conditions, certain medical conditions. And Mickey said that in many cases, AI is assisting clinicians in helping to better determine the best treatments for patients. So overall, AI has been very beneficial and could potentially close some of those health equity gaps.
I'm looking forward to hearing what Mickey has to say about AI because it really is such a promising technology, specifically in this field. Before we dive into your conversation, one last question. I know that ONC is collaborating with CDC on multiple efforts. What did Mickey say about the progress they're making with these initiatives?
Mickey said ONC and CDC have a number of collaborative projects they're working on right now, including the Data Modernization Initiative, which is helping CDC significantly enhance its infrastructure following the COVID-19 pandemic. The agency is also working with CDC on an effort called Moving Forward, which is a different way of thinking about the organization of CDC and the public health effort. And it's helping them get better interoperability across the public health ecosystem. So they're working on another project called the North Star Architecture, which is designed to support efficient integration of public health data systems using modern technology. So they've got a lot of great things they're collaborating on right now.
Well, I'm excited to hear more about that. So let's not keep our audience waiting. Let's take a listen to your conversation.
Today, Dr. Mickey Tripathi, the National Coordinator for Health IT at the Office of the National Coordinator for Health Information Technology, will be speaking with me about how the latest version of the U.S. Core of Data Interoperability is reducing health disparities, how ONC is using technologies to close health equity gaps, as well as how the Health Equity by Design approach is helping to build a more equitable future. Hi there, Mickey. Thanks so much for joining me on HealthCast.
Hi, Nikki. Happy to be here.
So before we get started, Mickey, can you please introduce yourself and briefly describe your role at ONC?
Sure. I am the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services, which is quite a mouthful, I know. We're a staff division in the Department of Health and Human Services, and we have two primary missions. One is helping to facilitate consistency in the use of health information technology across the U.S. government. So working with our Department of Health and Human Services fellow agencies, as well as with the VA, DoD, other organizations across the federal government in sort of kind of aligning our approaches to a more consistent and coherent health IT strategy. And then the second big mission focus is working with the market. So doing everything we can to help to promote, encourage, facilitate the adoption of open industry, standards-based technologies for better sharing of information, better availability of digital information, better sharing of information, more responsible use of information, all in a manner that best serves patients.
Great. Well, let's jump into our conversation. Health equity is a top priority for ONC. The agency released the U.S. Core Data for Interoperability, draft version 5, earlier this year. Can you start off by sharing the updates of this latest version and how will it help reduce health disparities and provide better health outcomes, especially for those in underserved communities?
Sure. So health equity is a big focus area for ONC as well as the entire department and the U.S. government at large, which is the Biden administration, and we're all in the Biden administration very focused on equity related issues wherever they reside. And then certainly with the health focus here in the department, we've got a particular focus on health equity types of issues. And we sort of think of the issues as being important enough that they ought to be considered sort of more fundamental kinds of design criteria or fundamental uses that that ought to be given sort of deeper and broader consideration in the design, development and implementation of health information technology, which is why we have been approaching it from what we call a health equity by design perspective. For those who are familiar with software development and business processes, business process design and other areas, things like safety by design and security by design and privacy by design are pretty well-known constructs where the idea is that those are so fundamentally important that you don't want to be thinking of those as like an added feature or something you bolt on later to whatever you're doing. You start from the beginning saying, this has got to be something that's focused on advancing health equity in this case. So that's kind of the approach that we've taken in general, more as like a philosophy. And then as we look at all of our internal activities as well as our mission areas, we think about how do we think about that from a design perspective, and how do we help others think about it from a design perspective and give them some of the fundamental building blocks for them to be able to, sort of build their systems with health equity types of information available to them in the best manner possible, so that they can, in their own environments and in their own implementations, adopt a health equity by design approach. And so, from our perspective, one of the different levers that we have available to us, one of the the most important levers in general, as well as and in particular in the health equity area, is in data standards that we approve, and we sort of adopt data standards, and then we make those a part of our regulatory framework for things like interoperability requirements, for certification of electronic health records, and other things. So the US CDI, I think, as you pointed out, the US Core Data for Interoperability is a set of data standards that that was defined in the 21st Century Cures Act of 2016 that directed ONC to create a minimum data standard essentially for the healthcare system. And so that's, the US Core Data for Interoperability stands for, I was going to say the US CDI stands for the U.S. Core Data for Interoperability. And what that is a set of, it's kind of like the minimum data set that you could expect to be available in any provider system if you were to go to any arbitrary provider system where, regardless of specialty, regardless of, setting, whether it's acute or ambulatory or whatever it is, the idea is we ought to have a base that we can always count on to be available. So should, you, Nikki, show up in the emergency department somewhere outside of, where you normally get your care, that organization would be able to request your record and know that they would get a minimum data set that covers, sort of like a medical snapshot of your medical history, so that then they could, make appropriate decisions about your care. And so what we've done is we put that into regulation, and we require that that electronic health record vendors that are certified by us, which is almost all of them, support those data standards. And so increasingly, more and more, federal programs are aligning around the US CDI. So it's become a very important construct. So getting to the health equity piece of it now is like, if you've got that as your foundation layer, meaning you're building an EHR and you have to support this minimum data set, and the EHRs, that we certify cover 97% of hospitals, 80% of ambulatory physicians, that's a really strong foundational element. And so we've added a number of data elements since we came in this administration, starting with the US CDI version 2, version 3, we're now up to US CDI version 5, but starting in US CDI version 2 and working our way all the way up, we've been incrementally every year adding more and more data elements that are important to health equity considerations. So for example, social determinants of health. We've added a number of data classes for the capture of social determinants of health information. Additional demographic information like tribal affiliation, for example, which was not available before in the demographic status. There's a number of others related to LGBTQ related issues as well that we're able to capture, like gender at birth, things like that allow you then to be able to have information available to you to both measure whether there are health equity kinds of issues, and importantly, to act on those if that's what's called for.
Okay, perfect. Thank you so much. Well, Mickey, are there any current health IT initiatives underway at ONC to modernize public health data systems, enhance the user experience, as well as advance patient care?
Yeah, we're doing a ton with the CDC and the public health jurisdictions, all working in collaboration with them to support the efforts that they've had for the what's called the Data Modernization Initiative, which is a large investment that the U.S. Congress put forward for the CDC to be able to upgrade its infrastructure. And recognizing coming out of the pandemic that that our public health infrastructure is pretty creaky and needed a significant facelift, more than a facelift. It needed a platform upgrade. So we've been working very hard with them on that, and coupling that with another initiative at the CDC that's called Moving Forward, which is a reorganization or a different way of thinking about the organization of the CDC and the public health effort. So in particular, what we're doing with the CDC are a number of things. One is helping them with getting better interoperability in public health across different public health systems, because as you may know, our public health system is very decentralized and fragmented. The authority for public health actually rests with the states and territories. It doesn't rest with the CDC. And so it's always an ongoing collaboration between the federal government and state governments on what are things that are important to the country as a whole, and how do we work with the different jurisdictions to make sure that the federal government is able to get the information needed to support a nationwide, public interest, but completely respecting the authorities that states have for determining public health programs and for identifying the data requirements and the data sharing that happens, from data that is captured from within their state. So a number of things that we're doing there are, one is we've launched TEFCA, which is called the Trusted Exchange Framework and Common Agreement. That was another requirement from the 21st Century Cures Act to create a nationwide network for the exchange, the secure sharing of information among a number of different entities like providers, payers, individuals themselves, and public health. And we've stressed from the beginning that public health has to be a part of our interoperability framework as we think about, the next evolution of interoperability nationwide. So we're working now with a number of jurisdictions to bring them live on the TEFCA network this calendar year. And what that'll mean is that you'll be able to have secure, on-demand availability of connections between healthcare delivery systems and public health agencies, and between public health agencies themselves. So that would be public health agencies being able to share information with each other, like Texas, Arkansas, and Oklahoma, who are close neighbors, and obviously patients and viruses don't respect state boundaries. They travel all over the place, and so you want to be able to make sure that those adjacent agencies have the ability to share information with each other as appropriate, and to be able to do that securely. And then also to the extent that there are things that have been agreed to share with the federal government, they have a fast, easy, secure way to be able to share that information with the CDC and federal public health authorities as well. And then all of that just makes that much more efficient and much more secure than the system today, which really isn't a system. It happens, via phone and fax and all sorts of other things, and email is, kind of how that happens today. So that's one thing. I'll just point to two others quickly. The other two things I'll point to is we are also working with the CDC on upgrading the public health infrastructure that is purchased by jurisdictions, meaning states, territories, localities, and tribal nations. The systems that they purchase with federal dollars, we're working on, how do we upgrade those so that they are more modern, that they're more standardized, and that will give them the ability to have greater security, for example, which we know that cybersecurity is just a big and growing threat, and it'll give them better interoperability with healthcare providers, which is very important because that's where the data comes from, and we want to have public health agencies be able to share information back with providers as well. So a number of things that we're starting to explore there are the potential for certification of public health IT systems, which would be somewhat analogous to the certification that we already do for electronic health record systems that are purchased by healthcare providers. So in this case, it would, the corresponding thing would be jurisdictions that are purchasing health IT systems using federal dollars. Is there, kind of a way of being able to have everyone move forward using, a funding that's available to them to get to the next level of interoperability, and to be able to support things like FHIR APIs, the US CDI, for example, that we talked about before, all of those things that will give us a better posture for preparedness going forward. And then the last thing, just to mention that US CDI, since I just touched on it, we're also working with them on how do we establish a nationwide public health data model, which most people who are listening to this may be shocked to hear that we don't have a nationwide public health data model, but we don't. We don't have a consistent data model that we would say, here is the public health data set for the country. We have 64 different ones for each jurisdiction. And what we're working with the CDC and the jurisdictions on is saying, well, we've already got that US CDI that's supported by the vast majority of hospitals and ambulatory providers. Why don't we build a public health data model that builds on that, and that then would be more consistent across the entire country, which would make life a lot easier for everyone.
Yes, definitely. Wow, a lot of initiatives underway. So that is wonderful to hear. Well, when it comes to electronic health records, I know you've mentioned that already, but what technologies is ONC utilizing to address algorithm bias and help close those health equity gaps?
Yeah, so we ourselves don't deploy technology per se, but what we do is we, through our regulations and through a variety of different regulatory means, we can help to influence and shape the direction of health IT adoption to make sure that it's in the public interest, that it's non-proprietary, based on solid open industry standards, that we've got security in place, and that uses are responsible. In particular, for example, now AI is rapidly growing, and the use of AI and algorithms in general for analytics as well as for automation are rapidly expanding across the healthcare delivery system. And one of the things that we've observed, and we started this work actually in the summer of 2021, so that we've actually been working on it for quite a while. Was this question of algorithmic bias, which I think is one of the things you were pointing to. And the issue is basically it's going back to this health equity with this health equity thing, that with the growing adoption of algorithms, and some of them by their nature are kind of black boxy. It's hard to know what's going on underneath them, like a large language model like Llama or MedPalm or ChatGPT or GPT-4 or GPT-5. Name your large language model. They by their nature aren't explanatory, meaning you don't really know exactly how they came up with the results that they did. And so with the growing adoption of those kinds of systems and applications on top of them, we thought that it would be very important to have sort of greater transparency about the use of those systems in electronic health records, because increasingly for a patient, an electronic health record is kind of where the rubber meets the road in terms of where an algorithm or an AI-based tool could affect their lives. Often, more and more the data that's being used to train and create these models are coming from electronic health records, and the delivery of the AI-based results, the results from the algorithm that would affect a patient's life, are increasingly through the electronic health record system itself. As a clinician is making a decision, for example, about, is this cancer or is it not cancer, or what's the next best treatment, or are you high risk or are you low risk, or something as with what is seemingly as benign, but often isn't as benign as some people think. What's the best appointment time for you over the next few weeks? And all of those things are things that are increasingly in the scope of the way algorithms are used. And so we think it's really important that and all of those are available in the EHR system. That's actually how a clinician would see them, and so that's how a patient would experience them. So our regulation, which we finalized in December, requires that electronic health record vendors, who again cover the vast majority of hospitals, like 97%, and most physician offices, are required to create a functionality for transparency about the AI-based tools that are in their products. So it doesn't, we're not approving AI-based tools. We're not telling them, here's the ones to use, here's the ones not to use. We're not regulating the AI-based tools, saying that that you're not allowed to make this available in the market. Rather, what we're doing is we're saying that hospitals and doctors ought to be the ones who determine whether that AI-based tool is appropriate for their particular patient population and in their setting. So the requirement is for that functionality to be available in the electronic health record products, and that'll give the provider organizations more information so that they can make their own decisions. And we also included as a part of that requirement, what we think of as the nutrition label for the AI model. It's like 31 data elements that kind of give you a sense of, well, what's in this model? Like, how would I, how do I assess from a health equity perspective? For example, we put in what were the patient demographics of the training data that the model was designed on, for example. And has the model been assessed for health equity related issues, for bias, for example? Those are the kinds of things that our regulation requires. And it's required to be in place by January 1st, 2025. So the HR vendors are hard at work, to make that available within, in 9 months now.
Oh, wow. That's great. Well, Mickey, I know ONC has released a white paper on health equity by design. You talked about this a little bit earlier, but I wanted to know if you could elaborate a little more on the health equity by design approach. How will it eliminate individual disparities and build a more equitable future?
Yeah, well, I mean, I would love if it could eliminate health disparities. I mean, that is the ambition for sure. We know that there are a lot of factors involved in that, and and so we're not certainly not pretending that we can snap our fingers and eliminate health disparities. But going back to what I was talking about before, I mean, we do think that it's a very important construct from that ought to be thought of at every stage of developing, designing, and implementing health information technology. And so, the approach that we've taken is, I talked about data and the importance of doing it from a data perspective. As we think about, our policies, for example, we, start to think about, things like AI, for example, which we've already talked about as being another area where, our focus there was on health equity, and then it expands, to safety and other considerations. But all with an eye towards saying, how do you make sure that that health equity considerations are at the front of everyone's mind as they're thinking about sort of the uses of technology. So one example of that would be the importance of the regulations that we had in AI, for example, and having health equity be a part of of the consideration of the use of AI enabled tools. Is there have been examples, documented examples, for example, of what might be seemingly simple algorithms that turned out to have pretty profound health equity implications. So, for example, it's a well documented by Zaid Obermeyer and other researchers of an algorithm that was made available by a health insurer to direct care management resources to patients who were seen as being more complex, and therefore would benefit from having more care managers assigned to them to help navigate the complexity of their condition as they dealt with multiple specialists and primary care and acute care hospitals, right? All of that, and all of it totally reasonable, right? I think we'd all agree that's a totally reasonable thing to do. Right. Absolutely, and it probably contributes to lowering the cost and increasing the effectiveness of care. Well, the problem arose when that health insurer said, well, how do we measure complexity of a patient? Well, I know. Why don't we use cost? And we'll say which patients seem to be higher cost patients, meaning that we've spent more money on them, and those must be the ones who are more complex, right? Mm-hmm. Sure, that seems reasonable. So they rolled out the model, not really considering from a design perspective, and this is where health equity by design would come in, where when you sort of take that first step and saying, I'm going to use cost as a proxy for complexity, the first question we would say that should come to your mind would be, are there any health equity issues related to doing that? And the answer is a profound yes, which is, wait a minute, cost means that you actually have the resources to get care in the first place. And that means that the people who have better insurance are the ones who are going to have more cost, because they are the ones who have insurance that will actually pay for their care. And so that's actually probably not a great measure from a health equity perspective, because those who are on this lower end of the socioeconomic stratum are not going to have good health insurance, and they're basically not going to be getting the care that they need in the first place. So almost invisible to the healthcare system. And so what that algorithm ended up doing was directing more care manager resources to people who were disproportionately white and disproportionately middle upper income, and because they had good insurance, right? It was doing the exact opposite of what we wanted it to do. So that's just one example of how we've been trying to, and part of the motivation for releasing that health equity by design paper is just to say there are things like that are all over the place in healthcare as we think about this, and we're starting to think about that from a policy perspective, and we want the industry to sort of give us ideas and things I'm sure that we haven't thought of, to say, how should we be thinking about this in a systematic way? And what are the other things that we can do to make sure that everyone is thinking about this from a design perspective?
Right. That makes total sense. Well, can you please tell me a little bit about the ONC Health IT certification program, and what impact will it have on health equity related data?
Yeah, the connecting some of the dots here, the ONC certification program, the Health IT certification program, is one of the sort of one of the biggest things that we do as an agency, because even though the certification is voluntary technically, as defined in the statute that that gave ONC the authority to certify electronic health record systems, it's voluntary, but it does, as I was describing before. Now, almost 97% of hospitals and 80% of ambulatory providers use a certified electronic health record system. And they do that because if they participate in certain CMS programs, certain Medicare and Medicaid and model programs from CMS, they're required to use an electronic health record system. So that's how we work in partnership with our federal agency partners to say, all right, what are your requirements? Now let's make sure that that we build that into certification. And what certification has done over the years, I think, is that it has created a floor, a foundation for for creating the digital healthcare system that all of us want for the 21st century. And without that standardization, what we would see is wildly different technologies being used all over the place, incompatibilities. They wouldn't be able to connect to each other. We wouldn't have standardized data that you can share from system to system. We wouldn't have the kind of public health reporting that, even though it was very deficient in many ways during the pandemic, the very fact that we had information on vaccines, for example, the very fact that we had the ability for all of us to get telehealth during the pandemic, when we couldn't physically go to the doctor's office, the fact that we could actually be talking to our doctor via a computer, all of that is resting on the certified electronic health records that have been deployed over the last 10 years. So it's really an amazing thing when you step back and think about it, because our system is so fragmented in almost every dimension you can think of, across geographies. Healthcare is regulated at the state level. We've got 1,000 different health insurers across the country. We have tens of thousands of hospitals and physician offices, and everyone is like going across all of these. It isn't really a system in a way. I mean, it's a very loosely coupled set of organizations that kind of work together occasionally and often not very well. But one of the things that connects them, that gives it systemness, is the fact that their electronic health records are all based on the same set of standards, and they can talk to each other. And we're not pretending that that's perfect, right? It's absolutely not perfect, and it can always be improved. And we're working very hard every year to improve that. But the fact that they actually can talk to each other and they can share data with each other, and the fact that if you go to Nome, Alaska, to a hospital, or to Sarasota, Florida, to a physician office, what you'll get out of that electronic health record system is pretty much the same. Like, it's very consistent what you can get out of those systems, despite the fact that we're a very big country and there's a lot of room for variation there. I think that's a tremendous value to the country. That's really important. And now increasingly, as we think about health equity and other things, it becomes, and AI, as we're talking about, it becomes a very important lever for us to make sure that there are important public policy objectives that we can make available across the country, right? If we didn't have the certified electronic health records, for example, we would have no ability to say, you have to support these data elements that are important from a health equity perspective, right? You wouldn't be able to do that, except for the certification program, which has that tremendous amount of power, I think, in terms of serving us as a country. Last thing is, we've now we're at the place, and I think that what the certification program has done is it's meant that we now are digital in many ways. Like, if you look back at 2010, 2011, the adoption of electronic health records was something like 10%. And now it's, I've already said these numbers, I'm going to say them again, 97% in hospitals and 80% in physician offices. And that means that for hospitals and healthcare systems, we're like digital natives now, right? We can start thinking as digital natives and not thinking about paper-based processes. That's another huge benefit I think the certification program has brought us. And we're going to start to see the real payback on that over the next few years, because it took a long time to get that in place, but now we're going to start to see the returns on that investment.
Right. Well, I know that ONC has partnered with CDC on many projects. I like the Moving Forward initiative that you mentioned earlier. And I know that ONC is working with the agency on other projects like the North Star architecture and Helios. Can you please provide updates on these? What progress has been made, and what are some of the challenges that you faced?
So those particular projects are, the North Star architecture is kind of a blueprint, which is and a part of the broader data modernization initiative, which is to say, how do we have more cloud-based approaches, for example, to the deployment of technology in a very heterogeneous and and very disparate, kind of landscape. So, we've got 64 jurisdictions across a very big country, for example. And that doesn't even count, all the sub jurisdictions like cities and counties, and like my city here, Newton, Massachusetts, has its own public health agency right here.
Wow.
So you've got literally thousands of public health agencies across the country, and right now each of them like buys their own technology. I mean, they literally are buying their own technology and then deploying it and hoping and praying that it connects up with other systems and that it's somehow consistent, so that if we have a real need from an emergency perspective, like the pandemic, for example, that it can actually respond. And what we saw again during the pandemic was the system didn't respond because it's not a system, because it was never designed to be able to do that. So the North Star architecture is is a blueprint for saying, how do we make as much of that available as cloud native kind of capabilities, where the CDC, for example, can support jurisdictions and say, you know what, we can actually share infrastructure and do what the rest of the private sector does, in their sleep every single day, which is they deploy technologies in cloud environments that allows the protection of that data from going anywhere where you don't want. So, the state of Massachusetts, the state of Connecticut, the state of Rhode Island can be hosted in the cloud. Their public health agency infrastructure can be hosted in the cloud, but they still have complete control over who has access to it. But what they get is the benefit of scale. Those are the kinds of things. Why is every jurisdiction purchasing their own technology to match patient records or to de-identify patient information if they want to be able to share it outside of the organization, for example, for de-identification purposes? And right now, every jurisdiction purchases their own technology to do that, which means they're incompatible and they're inconsistent, and it's a really expensive way of doing business, rather than just saying, you know what, we're all public health jurisdictions. We can buy that once, build it once, make it available for you in the cloud, just like I consume Netflix every single day. Well, I don't consume Netflix every day, I wish. But right, just being able to do it that easy, that efficient, but have it be in the public interest rather than just for us to be able to watch videos every night. That's what the North Star architecture is about.
Well, thank you so much for that. Earlier, you shared some of the great initiatives that are currently underway at ONC. Mickey, do you mind talking about any future initiatives? Are you excited about any future IT initiatives at ONC?
Yeah, totally. I'm a bottomless pit of excitement for for ONC for sure. So yeah, I mean, I think just in general, in just to give a little bit of context, which kind of relates a little bit of what I talked about before. We as a country, and ONC has been at the center of this. I'm working with our agency partners like CMS, CDC, and others. Have been spending now since 2010, which was when the HITECH Act passed, which gave ONC the authority to certify electronic health records and gave CMS, Medicare and Medicaid, the authority to make incentives available to providers to use to purchase electronic health records, right? And that started us on a $35 billion journey of implementing electronic health records, converting our paper-based healthcare delivery system to a natively electronic or natively digital healthcare delivery system. And that took a ton of time, $35 billion and 10 years, 12 years for us to be able to accomplish that in what I would argue is, the most complex and the biggest sector of the most complex and biggest economy that the world has ever seen. But in that time, it was, very messy, took a lot of work, a lot of blood, sweat, and tears, but we did it. And now here we are at the other end. And we're able to look back and say, wow, I'm standing now on top of this digital foundation and looking at what are the things we can do. That's why I'm really excited about, where ONC is and what we're now able to do going forward. So the things that, that I think are really exciting for us in looking forward in that, in that context are one, being able to now start to focus on what are the additional value-added things that we want to be able to do. So, for example, tying back to our health equity conversation for a second, one of the things that was announced in the HHS data strategy that was released just last year, I think, is that ONC is being asked to expand our scope to include human services interoperability, human services data. So we tend to focus on healthcare, which is hospitals, physician offices for when you go and get care when you're sick. But we always try to remind ourselves we are the Department of Health and Human Services. Human services, the whole other side of it. And when you think about health equity, you have to think about human services because though many of those programs are specifically designed for people at the lower end of the socioeconomic stratum, right? Things like SNAP and WIC and programs like that. And so increasingly, we want to be able to say, well, how do we have integration of those? Because we want to be able to take care of people before they get to the hospital or before they get to the doctor's office. And, in many cases, for example, thinking about the social determinants of health data elements that we talked about before, for a lot of people, because of their social situation, it may be that getting them better housing is actually at least as important for them as referring them to a cardiologist, right? It may be that that's or getting them better food is a better use of their next available dollar or the next available time than referring to them to yet another specialist. And so that kind of social services integration we want to be able to accomplish in the same way that we've been able to do on the clinical side. So that's the importance of the departments turning to us and saying, hey, we need you to now focus on human services interoperability. So when I'm sitting in an electronic health record in a hospital, I can say, I'm going to enroll you in the asthma program, the Boston City asthma program. And here I can click this button and make a referral to you to the Boston City asthma program. And now you go and visit them just like you would visit a specialist, for example, just like you'd visit the other hospital. And they already know you're coming. They've got your enrollment information, and then you can sort of pick it up from there. So that's the kind of work that I think is really exciting for us is starting to reach out into the other parts of the healthcare domain. Behavioral health is another area that we're starting to pay a lot of attention to as we think about interoperability and starting to go into the next level of information that's really important for us as a country is areas like research. So we're doing work with NIH and FDA, for example, on how do we extend the data standards for cancer. So we have we call it USCDI Plus, but we have a big initiative with the National Institutes for Health, with the White House Cancer Moonshot team and the FDA to expand data elements to support research and diagnosis and treatment of cancer, to be able to have better interoperability, in that area. So that just gives you a sense of, all the things now that we're reaching out to say, here are other areas now that we're digital. We can start thinking about, solving real problems and not just building that infrastructure.
Awesome information that you shared, Mickey. I really enjoyed our conversation, and I appreciate you taking out time to tell us all about the wonderful initiatives underway at ONC and how they're helping to advance health equity. So thank you so much. I really appreciate this, and I hope that you have a wonderful afternoon.
Likewise.
Thank you, Nikki. That was a great conversation with Mickey Tripathi. Before we let our listeners go, are there any last highlights or takeaways that you want to leave them with?
Of course, just a few. Like I mentioned earlier, Mickey emphasized that health equity is top of mind for ONC. The agency is focused on the health equity by design approach, as well as USCDI, which are, like I mentioned earlier, geared towards reducing health disparities. ONC is also has this wonderful partnership with CDC, and they're just making so much progress with the data modernization and moving forward initiatives. It's really just an exciting time for ONC. And in the end, it is all about closing the health equity gaps, providing data equity, and just better health outcomes for everyone, including those in the underserved communities.
Health equity is really such an important topic, and I really appreciate getting to hear more about how ONC is using emerging technology like AI to close these health equity gaps and improve health for all. So thank you again, Nikki. Listeners can tune in next week for a brand new podcast in our GovCIO Media and Research podcast feed. But until then, if you like what you heard, make sure you leave a review and a 5-star rating. on the podcast platform of your choice. I'm Alexander Bolova.
And I'm Nikki Henderson.
Thank you for listening. HealthCast, along with GovCast and Cybercast, is a production of GovCIO Media and Research. To explore our content, visit our website, govciomedia.com. Keep an eye out for new episodes every Tuesday. And if you like what you heard, leave us a review on the podcast platform of your choice. Have a topic you want us to discuss? Contact us at newsletter@govcio.com.